Hello, I'm Dr. Judy Salerno, President of the New York Academy of Medicine. Today, we are introducing a new series of informational programs for the public that we're calling Around the Table. Throughout the year, our board chair, Dr. Wayne Riley, and I will discuss issues related to health equity at the heart of our mission, with specific relevance to the times we are living in today. We want to share conversation with you, but we don't want it to stop there. After each program, we'll offer resources and recommendations for action steps that you can take. While we'll not be able to touch on every subject of importance, we're going to give it our best shot to tackle what we believe to be some of the most pressing issues in health equity. Again, we hope you will listen in, engage, and take action, because making meaningful change will take all of us working together. Our first program today is about vaccine confidence, specifically among communities of color, and what we can do to address this challenge. We invited Dr. Bernard Lowe, a renowned bioethicist, to be with us today for Around the Table discussion. Thank you for joining us as we examine this important public health challenge. Come join the discussion.
I'm Dr. Wayne Riley, president of SUNY Downstate Health Sciences University and professor of medicine and health policy, also at Downstate, and chair of the New York Academy Board of Trustees. And it's my honor to welcome you to this Around the Table, Tackling Health Equity Issues Together. This is an exciting program that we have organized at the New York Academy of Medicine to shed information, to share insights, and to, most importantly, talk to leaders who are working on the COVID pandemic, particularly the vaccine issues in minority and communities of color. And we think this is a wonderful opportunity for us to contribute to the work that we all must be passionate about during this pandemic, particularly at this critical time when the rollout of the vaccines is picking up steam. We're getting more traction. We've even seen an uptick in communities of color in terms of their embrace of getting a vaccine. So this is a critical conversation that we're so delighted that you could join us with. I will now turn it over to the illustrious president of the New York Academy of Medicine, Dr. Judith Salerno, who will set the context and introduce our esteemed presenter and discussant. Dr. Salerno.
Thank you, Dr. Riley. I'm Judy Salerno, president of the New York Academy of Medicine, and I am delighted today to introduce our guest, Dr. Bernard Lowe. Dr. Lowe is President Emeritus of the Greenwall Foundation and Professor of Medicine Emeritus at University of California in San Francisco, and I may add, a personal friend and colleague of many years. He recently co-authored an article with Dr. Douglas Opel and Dr. Monica Peek in the Annals of Internal Medicine entitled Addressing Mistrust About COVID-19 Vaccines Among Patients of Color. So, Dr. Riley, will you bring us to a discussion of why this is important and why we're around the table today discussing this issue?
Well, Dr. Salerno, these issues and topics are critically important, but more important is the actions that we can take after and through these discussions. So, we tend to have a bias for action at the New York Academy of Medicine, which is quite different than our perception at times. But we embrace actions and action steps and tactics and strategies that can address such issues as COVID or health disparities, or specifically now to COVID, the whole issue of vaccine hesitancy and how we can get all communities, particularly minority communities, to embrace and adopt getting the vaccine. So action is hopefully something that we will model for you in terms of this discussion and some of the tactics that we will share with our distinguished panelist, Dr. Lowe, who's one of the giants of medical education and advocacy and in community improvement, all the great things, Dr. Lowe. You'll learn about him in a little bit later from Dr. Salerno in particular. So that's the way we see this.
Thank you. Well, recent information coming out from the Kaiser Family Foundation Vaccine Monitor tells us while nearly half of older adults say they've already gotten the vaccine, only a third of Black older adults say the same. And Black and Latino adults continue to be more likely than whites to say that they'll wait to see before getting vaccinated. So about a third of Black adults say that they're waiting to see what happens with the vaccine rollout. And Latino adults, only about 26%, but still a significant portion say that they will wait and see, while only 18% of white adults say so.
Well, again, Dr. Salerno, as you mentioned, one of the challenges that we have in taking care of communities of color, particularly African Americans, is quite frankly the well-earned distrust that African American communities have, unfortunately, with our healthcare system. It dates back to slavery times when slaves were poorly treated or mistreated, experimented on in terms of therapies. And then fast forward to more modern times, the unfortunate saga of the Tuskegee syphilis experiment, where semi-literate African-American men in Macon County, Georgia, who were found to be syphilis positive were not offered treatment at the time of their diagnosis, nor were they offered the definitive treatment of penicillin once it became FDA approved in the late 40s and early 50s. And so that is looked upon as one reason why we should potentially not embrace the vaccine. And then other situations, the day-to-day disparate treatment that Black patients have, unfortunately, in many healthcare institutions. So that mistrust is well earned, but that mistrust has to be overcome in the specific case of COVID. We have to acknowledge, not denigrate those who have feelings about the mistreatment, but use the history as the foundation for progress in this particular issue, because the disproportionate impact of COVID on Black and brown communities is real, it's persistent, and it's worrisome. And that's why the vaccines are, in my view, as a physician and scientist, a critical component in how we address that.
Well, it's interesting. I heard a comment recently when someone was asked, why don't people of color trust the vaccine? And the person in the conversation turned it around and said, well, why isn't the healthcare system trustworthy so that people can have faith in the care that they'll receive or the safety of the vaccine? So I'd like to ask Dr. Lowe to share some of his views on this issue and to talk us through the specific strategies that he and his co-authors wrote about on the topic of how to discuss vaccine hesitancy with patients. Dr. Lowe.
Thanks very much. It's a real pleasure to be here today with the New York Academy of Medicine. Let me start by saying, although patients have a lot of reasons to mistrust medical institutions, they tend to have a high trust in their own personal physicians. In fact, people say that their most trusted source of information about COVID vaccines is their own physician. And physicians are actually rated more trustworthy on this than the CDC, even more trustworthy than Dr. Fauci and President Biden. So I think when you've been as we all know, when you've been taking care of a patient and really engaged with them for their benefit, they come to trust you. And we can use that to help them think through decisions about vaccine. So in the article, we had set 4 suggestions. I've added one more for the talk. And they are: first, listen, don't talk. Second, engage the patient collaboratively. Third, tailor the discussion to the patient's specific concerns. 4, describe the process of vaccine development and approval if that's an issue for the patient. And finally, acknowledge uncertainty and knowledge gaps about these vaccines. So I'm going to talk about each one in more detail now. So first, listen, don't talk. As doctors, we have a lot of expertise that we want to share with our patients, but we also have a bad habit of cutting in on patients before they've really had a chance to tell them their concerns and for them to feel listened to. So I think the first thing is to really listen to and understand the patient. And to do that, there are techniques that are very helpful, using open-ended questions. What have you heard about the COVID vaccine? What are you thinking about the COVID vaccine? And then use open-ended questions to go deeper to understand what the patient's perspective. Tell me more about why you feel you can't trust medical institutions. Second big recommendation is engage with the patient. We can reflect back what we heard the patient say so they feel that we really understood them, that they've been listened to. Patients who feel that tend to be more open to then hearing what we have to say. So we can say things like, I hear that you're concerned about not wanting to get the vaccine at this time, but to put it off some. Another good communication technique is to affirm the patient's concerns. We can say something like, you're not alone in feeling this. I have a number of patients who have that same concern. I think it's important to support the patient's autonomy to make decisions, to say, I just want you to know this is your decision. It's yours to make. And finally, to avoid premature information or reassurance. Wait till it's time and they're ready to really want to listen. So our third general recommendation is to tailor the discussion to the patient's specific concerns. There are a number of concerns that we commonly hear. We've already talked about mistrust. Other things that patients will say is that I hear the vaccine can give you COVID. I hear the vaccine has a microchip so the government can track you. I hear the vaccine will make you sterile or interfere with your genes. Or I hear that after the shot, you'll be too sick to go to work the next day or two. Knowing what the patient's specific concerns are allow us to tailor that discussion to those concerns. Our communication specialist colleagues talk about something they call roll with the resistance, which is when the patient raises a concern or an objection, to invite the patient to say more. Tell me more about what you've heard about the vaccine giving you COVID, rather than trying to say, well, that's not true, let me explain why. Another good technique is to focus, try and redirect the focus away from what they're concerned about to what the patient might gain from getting the vaccine. So what would you like to do that you can't do now because of COVID? And a lot of people will say they want to visit their parents or their grandparents, or if they're older people, they want to visit their grandchildren. And I think most people would say they would really like to get together with the family in person for Thanksgiving and other holidays. So fourth recommendation is to describe the vaccine development and approval process if it's an issue for the patient. So explaining how the vaccine works is important if someone's concerned that it's going to make them sterile or interfere with their genes. One particular concern which people may have centers around the use of fetal cell lines in the development or the manufacture of the vaccine. And obviously patients who are opponents of abortion will have concerns about the use of fetal tissue. It's important to help people understand that these are old cell lines developed 1972, 1985. There are not new fetal cells being used in these vaccines. And how they were used varies from vaccine to vaccine. For the mRNA vaccines, that's the Pfizer and the Moderna vaccines, these fetal cell lines were used early in the proof of concept part of the development to demonstrate that the mRNA could get inside the cell and start to express the spike protein. They're not used in the manufacture of those vaccines. But for the adenovirus-related vaccines, and that's Johnson & Johnson and AstraZeneca, which has not been approved yet in this country, but is used elsewhere, they actually still use old fetal cell lines to grow the adenovirus for manufacture. Now, religious leaders from various traditions, Catholic, Protestant, Muslim, have talked about this. And we shouldn't, as doctors, be in the business of giving religious advice, but I think it is important to refer patients who have these, to acknowledge the concern, to refer them to religious sources of information to have a balanced view. And many of these religious leaders go through the arguments, but end up saying that it's not morally appropriate to use the vaccine and even to use the Johnson & Johnson vaccine if there are no alternatives. So the fifth general communication strategy we suggest is to acknowledge the uncertainty and knowledge gaps regarding COVID vaccines. And this is a very fast moving epidemic, and we don't really know how well these vaccines will work against some of these new variants that are becoming more and more common and even predominating in some states. There's some preliminary evidence that for the vaccines that have been approved in the US already, they still are effective against some of these strains, but less effectively so. They still work, but not quite as well. But we don't know, for example, how this new strain that's been identified in Brazil, there's evidence that the AstraZeneca vaccine may not work effectively against that. We also, frankly, don't know how long this benefit lasts. Is it one shot and that's it? Or will we need booster shots? So let me just try and summarize what I said by reminding us that these are communication skills that as practicing physicians, we use all the time in our daily practice. So when we discuss with a patient their refusal of a beneficial cancer screening test like mammography for someone of the right age, woman in the right age group, when we talk to a patient who has discontinued his anti-diabetic medicines, and also when we talk to patients and their families about end-of-life decisions, we use these communication skills, perhaps not explicitly referring to them, but we're used to doing it, and we can take these same skills and adapt them to the COVID vaccine situation. So let me stop there, and I'm looking forward to a discussion with Dr. Riley and Dr. Snyder.
These are great points. Thank you. And, it brings up so many questions. We're learning so much as we go along. It seems that each day, each week, we're learning a lot of information about the behavior of the virus, about how well the vaccines are working in different situations. Just today, the CDC came out with information that there seems to be the same kind of efficacy in the general population for the Pfizer and Moderna vaccines as there were in the studies, in the research studies. But let me go to another point. We know, for example, that when people of color see physicians and clinicians who look like them, that they do better, that they listen better, and they have better outcomes. So what about a person like myself? I'm a physician, I'm not African American or Latino. So how do I begin these conversations and with my patients? And why should they listen to me as opposed to listening to a family member who might be opposed to the vaccine?
Well, great question, Judy, and I'll jump in. I know Dr. Lowe wants in on this too, but let me go back to something Dr. Lowe started with his first, piece of advice, and that is to listen to the patient before you talk. One of the biggest criticisms Black patients have about us, meaning doctors, is they don't listen to me. And therefore, since they don't listen to me, I don't like going to a doctor. I don't like going to a hospital. And, there's been celebrities, African-American celebrities who have voiced the same complaint. Case in point, Serena Williams, with her history of DVT, blood clots. And she said, I told the doctors, that I had this history and I know my body, and they wouldn't listen to me. And she almost died. So she is poster child number one, if you will, for an African-American who interacts with a doctor and the healthcare system who felt she wasn't listened to. So I agree with Dr. Lowe. The first thing is you basically, as I used to tell my medical students, practice the pause. When you ask the patient, Mrs. Jones, why are you here today? Let Mrs. Jones get to why she's here. Even though she may have to start with, I had to take 3 buses, or I had to take the subway, or my grandson had to pick me up after he got off work. Sometimes there's a little circuitous, storytelling here, but practice the pause, because the patient will get around to telling you why they're there. But you have to be patient in order to listen carefully. And that is one of the biggest criticisms Black patients have. So particularly, as Dr. Lowe said on the vaccine issue, listen to all your patients. But I would say practice especially strong listening skills with your patients who are Black and brown.
I couldn't agree more with what Dr. Riley just said. And I think when you do that, when the patients feel you have listened, that you care and you really understand and you're trying to do what's best for them, then they develop trust in you over a series of visits. And when they do, I think then it addresses the question Dr. Salerno raised, which is they know that we have expertise they don't. They may still go to the internet and to friends for advice, but they want to listen to what we have to say. And we can use that built up reservoir of trust and respect that patients feel on this particular topic, and just showing your concern about them, that you want to make the best decision for them. People want to talk about it as long as they feel they're not being judged, they're not being put down.
Right.
In I know that clinicians are always rushed, especially in a clinic situation where you're always looking at the clock and trying to focus on your patient, but knowing that the expectations are that you'll see a person in 7 minutes or 9 minutes or whatever the system dictates. But on the other hand, wanting to engage in this conversation, are we really set up to have these conversations in the clinic, in the doctor's office, in these settings?
It's a real challenge. And I think one of the things that we all have learned to do as clinicians is prioritize. Whatever time I have in this visit, what is most important? And as Dr. Riley suggested, sometimes the most important thing is helping the patient figure out a way to get to the clinic that's feasible for them, because if that doesn't happen, nothing else is going to happen. I've tried to say to patients, I know you've got a lot of problems, but if nothing has really changed, what would you think about talking about the COVID vaccine today instead of your blood pressure, your diabetes, and your breathing problems, unless it's important to you or unless something has changed since we last talked. So again, we often have too many things in one visit, but stable chronic problems maybe can wait, because this is really a public health crisis.
Great point. Yeah.
Right. I agree with that. And sometimes, Judy, particularly with Black and brown patients, you have to have a second conversation or a third conversation. And as frustrating as it may be to us as physicians, sometimes a fourth conversation with your patients about the vaccine. It reminds me of what you and I and Dr. Lowe have done as general internists. We've counseled patients on smoking cessation. And many of our patients have said, Dr. Riley, I can't, I've tried to quit. I've tried Nicorette gum. I've tried this. I've tried, biofeedback. And you know what I tell them? I said, keep trying. Because we know from smoking cessation research that it takes about 3.5 times for someone to attempt to quit before they're successful. So if you extrapolate that to the conversation about vaccines, it may take 3 visits or 2 visits, but don't give up after 1 visit. And I think Dr. Lowe is right. We're seeing evidence that patients feel like Black patients in particular are feeling more like they're being listened to. If you look at the Pew Research poll before Christmas, when African Americans were asked would they get the vaccine, it was maybe around 42%. It's now approaching 55% because of the work that Dr. Lowe and I and New York Academy of Medicine and you, Dr. Salerno, and physicians all over the country are doing to educate Black and brown communities about the vaccine. Listen to their questions, listen to them. So again, I think we're seeing evidence that this is gaining traction. And in psychology, we all know there is the phenomenon called the bandwagon effect, and we're seeing it in families. I hear from African American families where the grandmother said she got the shot, or the children got the shot, but the grandmother didn't. But when one gets it, then they start saying, well, wow, they're doing fine. They didn't drop dead, quote unquote. I think I will consider getting it. Or I think I will ask my doctor when I go back to see he or she. So again, these are the types of techniques that I used to teach my residents and medical students, that you have to learn to interact with your patient. Your patient is not just what's in the EMR. Your patient is not just that they have high blood pressure, diabetes, history of breast cancer, et cetera, et cetera.
So I think those are great points, Dr. Riley, and I want to just play out the smoking analogy a little bit. That it may take several visits. And also, people are at various stages of wanting to engage on the topic. So if someone says, I'm not sure it's right, I'd prefer to wait and see, I think there are opportunities there. I think if someone says, there's no way I'm getting this vaccine, even if they made it mandatory, no way that shot's going into my arm. I'm not sure that patient is going to be ready to have the kind of conversation. I may be better off spending more time with the patient who's a little closer to thinking about it. And I think people are ambivalent. They're conflicted. There's been some interesting reports in the news that when you talk to healthcare workers who are eligible for the vaccine, who have seen firsthand the ravages of COVID, many of them are hesitant. And many of them need several conversations. They need to see other people get vaccinated. They need to talk to people. How did it go for you? Did you feel sick? And so this is a long-term process. I mean, we'd like everyone to be vaccinated tomorrow. But again, if we can get to summer, start school again in the fall, have Thanksgiving and the holidays together with family, that's a big plus. We wish it had come sooner.
Yeah.
But I think, as Dr. Riley said, things are headed in the right direction, but we have to keep pushing.
Right.
Yeah.
You know, Judy, I'll follow that. Again, you know, in the African-American community, you know, trusted messengers are critically important. Even if, you know, African-American patients don't look at me necessarily just because I'm a Black physician as a trusted messenger. More than likely, their pastor, you know, the Black church is so integral to African-American life all over the country that even here in New York, we are tapped in to the African-American clergy. And I know Dr. Lowe and his team at UCSF are same thing in San Francisco and in the Bay Area. The African-American pastors have incredible, if you will, street cred with their congregations. And to the extent that we can engage African-American faith leaders of all denominations to be a part of this effort, that it is, you know, the protection of life. And you know, and Dr. Lowe mentioned earlier, you know, I'm Catholic, and I've listened to the Pope. The Pope has said unmistakably that these vaccines are appropriate for Roman Catholics to embrace, and Muslim and Hindu and rabbis have articulated, and swamis have said the same thing for the Hindu members of communities. So again, trusted messengers, you know, meeting people where they are is critically important. It's not just the three of us or people like us, Judy, physicians. It's the trusted messengers in communities.
Yeah, I remember as a young child lining up after Mass on Sunday at church and receiving my Sabin vaccine in a sugar cube. And all the kids lined up, and maybe we should be going into churches, and I'll volunteer to, you know, to go
we
into.
are. Yeah, well, we are, you know, in New York, and I know Dr. Lowe and I had a pre-conversation about this. You know, look, we can't just, you know, Black and brown communities can't just go to hospitals and clinics to get their shot. Make it convenient, put it in the community, put it at the YMCA, put it at the Boys and Girls Club, put it at the sports arenas that people, you know, attend and visit. So use community-based resources to stand up vaccine accessibility. And, you know, part of the other thing about you know, sometimes I think Dr. Lowe I'd be interested to hear what his view is. That it's not so much the hesitancy that some Black and brown communities have about the vaccine, is that they feel like it's not accessible.
Yeah.
I have to go across town, or I got to go, you know, or I can't, you know, I have mobility issues. It's the inaccessibility that sometimes can drive the hesitancy. Oh, I don't want to bother my family to, you know, take me across town, or it's such a hassle, you know, I'm not going to get it because of that. So again, making it accessible is critically important, particularly in urban areas.
So I think that's a really important point, that I limited myself to a very small part of the picture, which is talking to a patient in the clinical setting. But these decisions are based on a whole series of things. First, are you eligible to get the vaccine? Well, more and more everyone is. Can you get an appointment for the vaccine? So people who are able to do that are very tech savvy, know how to get on the website, know how to get through a busy line. But there's help for people who aren't that tech savvy. They're volunteers. In our clinic, the social workers put together a great sheet of resources for this. Transportation is so important. And it's not just the transportation, it's where the vaccine sites are located and when they're open. So if you're working and don't have health insurance and don't have sick days, you can't go to a vaccine site that's only open 9 to 5 or even 9 to 6. If you're going to take an elderly family member and pick them up and drive them, the hours have to be convenient. But again, there are now volunteers saying, I can help with that. I'm retired, I have a car, let me help pick people up. I think that this is a system problem we've got to solve on every single level. And hopefully now the supply will be less of an issue, the delivery will be less of an issue. But this, how to get the vaccine and the person to meet at the same place at the same time, that's always the last step of the delivery system is always the hardest.
Great. Well, Dr. Lowe, we're going to wrap up the Q&A, but I think as we wrap up the Q&A and if you will tie a bow around our discussion before I turn it back to Dr. Salerno, I want to again push our audience and our listeners to think of actionable items. What can I do as a physician, nurse, healthcare advocate, public health professional to further the cause of vaccines and vaccination of communities of color? So again, number one, learn the facts. The facts are these vaccines are incredibly safe and very effective at preventing serious disease and death, which is the key reason we want people to get these vaccines. If you prevent serious illness and death, you prevent hospitalizations and our hospital system from being overcome. You can prevent, suffering long-haul symptoms of COVID. You can prevent it bringing it home to your family or loved ones or your spouse or partner. So there's lots of reasons why these vaccines are safe. So learn the facts. Number two, click the link at the end of this program to read Dr. Lowe's terrific article in Annals of Internal Medicine, as well as other resources and information that the New York Academy can provide to you. But all the major organizations are doing it. We're not the only one doing it at the Academy. The specialty societies, I'm President Emeritus of the American College of Physicians, and I know the ACP has been providing excellent information for clinicians and others who take care of COVID patients. So there's so avail yourself of the resources. The New England Journal of Medicine has a terrific series, both audio and print, on COVID-related information. Look, Dr. Lowe nailed it on the strategies. In the old days, Dr. Lowe, you remember we used to put stuff like that under our ID badge,
3x5 card.
Oh, yeah.
Yeah. If we could put that under everybody's ID badge, your 4 strategies, or on a 3x5 card that you put in your white coat or your top pocket, or your scrubs. That is a visible, sort of tangible way that you can remember those strategies. Those strategies are terrific, Dr. Lowe. Thank you and your co-authors for highlighting them in the superb article. And then 4, share strategies and messages in the places of your work and social media. Tweet about it, Instagram, all of the social media platforms that many of you are way more facile than Dr. Lowe and Dr. Salerno and I in standing up and navigating. This is the way people get information. So use social media effectively. This is the time where we should be vigorous educators of Americans about the vaccines and about its safety, particularly in communities of color. So again, those are actionable, colleagues, actionable steps. And I would argue just a subset of actionable steps that you yourself can take with your colleagues in your practices, in your hospitals, in your community, in your clinics, that can really, really make a difference in addressing, this tough problem of vaccine hesitancy in certain communities. So, Dr. Salerno, I will turn it back to you now.
I would like to thank Dr. Lowe for joining us today. It's been an interesting and insightful conversations, and I will certainly have those 4 strategies behind my ID badge when I go into the clinical setting. And thank you. It's very important that we all learn together. And I thank you all for joining us for our first round the table discussion. More to come, and this is an important year, and we're all learning from each other. Thank you very much. Bye, everyone.